Good afternoon, everyone. Thanks for the opportunity for speaking here. So I was listening to the talks before I came here, and I do agree with thankfulness, gratefulness, and handling stress, and a big believer in the rehab. I participate in overall care of the patient by doing the valve replacement, but I totally agree that this is just part of the whole picture, and everything before and after is as important as doing the procedure successfully and carefully. So coming to this talk that we have today, we are going to discuss about aortic valves disorders and how we treat it. So talking about the heart, this is a pump that pumps blood to every ounce on our body. And it is an organ which is beating about 100,000 times every day for as long as we live. So it's doing a very hard work as other organs in the body, but if there is any obstruction in any place, then we need to fix that. So our heart is made up of 4 valves, and anything backs off, it leads to congestion behind it, and people present with different kind of symptoms. If you pay attention to this picture here, on the left side, we show the 2 chambers, upper and lower chambers of the heart, and you see the blood flowing from the upper chamber to the lower chamber, going to the lungs, gets oxygenated, comes to the left side. And then in the big red, you see that the aortic valve, that's the final place where, before the heart ejects into rest of the body, this valve controls the blood flow to rest of the body. So if this valve becomes tight or leaky, it's like putting a foot on the hose pipe that the blood cannot flow through this, and anything you do, anything exertional, you're going to feel some symptoms. And we're going to talk about those symptoms and what to do about it. So half of the adult population, including the older people, they have some form of heart disease, not just aortic valve disease, but some form of heart disease, whether manifest or not. And heart disease, it's not completely curable, but it is preventable and treatable with the strategies that some of them are managing your stress, like we were talking before. But aortic stenosis that we're going to talk about, it's a mechanical problem of the heart, and there's nothing you can do about it if you're just managing just with, gratification and thankfulness. That is an overall health, but this is something for which you have no control. So today we're talking about the aortic valve. So when you're young, your heart valve feels like on the top there's your opens valve and there's no calcification on it. But if you look at the bottom, you see how the calcification is there in the valves, and every time the heart beats, it's not able to open. And once it is totally diseased, you can see how barely it is opening there. So there's no medical treatment for this. Only treatment is to replace this heart valve. And this is a brief video for 4 minutes, which talks about it. And then I'll continue with the talk after this video.
The heart's main function is to pump blood to the rest of your body. The heart contains 4 valves. Normal valves have 2 or 3 flaps of tissue called leaflets that open and close like gates to control the flow of blood through your heart. Aortic stenosis is a buildup of calcium on the aortic valve leaflets, which causes the leaflets to become stiff over time. This buildup reduces their ability to fully open and close, decreasing blood flow to the rest of your body. Aortic stenosis is usually caused over time as we age, but can also be caused by a birth defect, previous chest radiation, or rheumatic fever. Unlike other forms of heart disease that are caused by genetics, diet, or lifestyle, and can be managed by medications, aortic stenosis is a mechanical problem that cannot be prevented. It can only be effectively fixed by replacing your diseased valve. Aortic stenosis is a progressive disease, which means it gets worse over time. It's typically measured as mild, moderate, or severe aortic stenosis. As a result of the reduced blood flow, the body does not get the oxygen it needs, which may cause symptoms. Patients who have severe aortic stenosis could experience a variety of symptoms that may be confused with simply getting older, including shortness of breath, fatigue or feeling tired all the time, difficulty walking short distances or exercising, lightheadedness, dizziness or fainting, chest pain, swollen ankles and feet, and rapid or irregular heartbeat. Sometimes when an irregular heartbeat or murmur is detected, it could be a sign of an underlying valve problem. Talk to your doctor about diagnosing the cause of your murmur. It's important to know that there may be no outward symptoms of severe aortic stenosis. If you have been diagnosed with severe aortic stenosis and are experiencing symptoms, the disease can be life-threatening and can progress rapidly. Treatment for aortic stenosis depends on how far your disease has progressed. If you have mild or moderate aortic stenosis and are experiencing symptoms, your doctor may monitor you and prescribe medications to help relieve any symptoms. Eventually, if your aortic stenosis becomes more severe, the only effective treatment is to replace your diseased valve. There are two effective treatment options for patients who have been diagnosed with severe aortic stenosis: transcatheter aortic valve replacement, TAVR, sometimes called TAVI, or surgical aortic valve replacement, SAVR, or most commonly called open heart surgery. TAVR is a less invasive procedure than open heart surgery. The TAVR procedure uses a catheter, which is most commonly inserted through a small incision in the leg, to implant a new valve within your diseased aortic valve. For patients who have been diagnosed with severe aortic stenosis, TAVR may be an option depending on your risk for open heart surgery. Surgical aortic valve replacement, most commonly called open heart surgery, is another option for treating severe aortic stenosis. Most open heart surgeries are performed through an incision across the full length of the chest, where your diseased aortic valve is removed and a new valve is sewn in. If you've been told you have severe aortic stenosis, only a properly trained, specialized heart team can recommend the best treatment option based on your overall health. Ask your doctor to refer you for a TAVR evaluation. To find a specialized heart team at a TAVR center near you, visit newheartvalve.com.
So this isn't brief about what we are talking about today, but most of the patients who are very symptomatic with this, they just live about 2 years after severe symptoms with aortic stenosis. So what are the causes of developing aortic stenosis? The most common is calcium buildup. Doesn't mean like some people take calcium supplementation and milk. It doesn't get added there. So if you need calcium, you need calcium, but this is a different kind of degenerative calcification. Congenital birth defect, some people are born with 2 leaflets instead of 3 leaflets that normally are there. So they present generally sooner. And then rheumatic fever is a condition which is not very common here, but more common in developing countries that can also contribute to development of aortic stenosis. And then some people who receive radiation for cancer treatment, they also can develop damage to these heart valves. What are the risk factors for this? Increasing age is the biggest risk factor, and that causes most of the aortic stenosis in America. And high blood pressure, cholesterol, smoking, deformed aortic valves, and family history. So what are the symptoms? So most of the times, the 4 main symptoms are chest pain, shortness of breath, fainting, syncope. But you can have other symptoms like fatigue, not being able to do activities that you used to do before. Sometimes patients come and they are in their 80s and they say that we are just slow, and they think that's all due to aging, which is true sometimes, but if they have this problem and that's causing this shortness of breath or fatigue, it comes gradually. It doesn't happen suddenly. So sometimes they don't even realize they have this problem until we diagnose it. So as it says here, About one of three patients, they don't even realize they have symptoms until we assess. And after everything is said and done, the valve replacement is done. Some of them, they report to us that now we know what normal feels like. So how we diagnose it? First of all, we need to suspect it. And once we do, we listen with a stethoscope, which tells us about that patient has a murmur. Then we do some other testing, including doing an echocardiogram, which is very important, that shows us what exactly is going on. And then there are other modalities that also help in this workup, including doing an EKG and chest X-ray. And then sometimes we do angiogram on these patients to check the severity of the stenosis. So despite diagnosis, a lot of patients still go untreated, and this is in 2016 that over 60% patients, despite having severe aortic stenosis, didn't get the adequate treatment. So what are the treatment options? Until you have mild or moderate disease, we are just giving you medications to relieve your symptoms. There is no way to stop the progression of this once it happens. If you have mild disease, we follow you with every 1 to 2 years, check an echocardiogram. If you have moderate disease, we see you every 6 months. And if you have severe disease, then that's the time that we should treat you. And treatment, it can be done in 2 ways. One of them is open heart surgery, and the other one is TAVR, which has become popular and has been going on in US since 2011. So these are the 2 modalities of treatment. Every patient that we see for aortic stenosis, once we decide how to treat them, is seen by a team of doctors. One of them is a doctor like me who does the TAVR procedure. The other is a surgeon who does open heart surgery, so that the patients get a chance to discuss what they are dealing with and try to understand the treatment process and what are the risks and benefits. So then we come to decide what is the best way to treat it. So first we talk about the surgical replacement, as it means it's open heart surgery. Chances of, because it's the high risk procedure, chances of having some high risk complications is higher with open heart surgery. And stroke, death, and bleeding within first year is about 3% incidence, and and it takes longer to do this procedure, about 4 hours. Your hospital stay is longer. But sometimes this is the only option because you need something else in addition to it, like doing a bypass surgery or doing 2 valve surgeries. Also, with this, we can put a mechanical valve in. Mechanical valves are supposed to last lifelong, and longevity is more. Generally, people who are less than 65 years of age, they go for open heart surgery unless there is some reason not to do this. And next is TAVR, which is a procedure that I do, and it is something that can be done with a short hospitalization. Most of the patients go home next day. Takes us about an hour to do the procedure. Complication rates same, but less chances than open heart surgery. So whoever is diagnosed with this, as I was telling you, first point of contact is your primary care doctor, who can refer you to us, and then we can do the further evaluation and decide what is best treatment to treat this problem. So next is TAVR procedure. So here we put a big tube in your leg arteries, and then we go up, cross the heart valve, and deploy it in that. In this, we are limited that the valves that we can use are called bioprosthetic valves, and in most of the US, we are using this Edwards valve, which is, depending upon your preference, whether you like steak or bacon, we can see which will fit better, but most of the procedures are done by this valve. It is a balloon expandable valve. Comes in 4 different types, depending upon what size will fit in everybody, we do this. And then the other one is the pig valve. It is self-expanding, and depending upon your anatomy, we pick between these 2 and take care of this. So what can you talk to your doctors about? So this is an important slide here where if you go to the doctor, what are your concerns and questions? Mainly it is not being able to do things you like to do and gradually slowing down. And once you talk, you just want to know if you have aortic stenosis, what kind is it, mild, moderate, severe? Are you a candidate for TAVR? And if you're not now, when you will be a candidate for that. And based upon that, we schedule your follow-up visits. And here is some more, if you want to know more about this. This is the last slide. So I can take any questions if you have any now.
So I have a question. Just chat. Okay. I have a question. What leads to the calcification? I mean, the calcium is in your blood, so why would it affect some people but not others? And the valve tissue themselves, I don't believe that they're really fed by a blood supply. So do you have any insight into that?
There is no such cause and effect relationship, but it's the degeneration of the heart valve which takes place. It's hard to say who will develop it, but if you have more risk factors for developing heart disease, like you have high blood pressure, you have cholesterol, the stress on the heart valve is more. So the more it has to go through that stress, that causes degeneration of the valve. And in terms of layman, calcium acts like a cement. So wherever there is a damage, it tries to repair that. But same thing happens in coronary arteries, that you have blockages there and the calcium gets deposited there. And eventually, when it keeps on depositing there and just causes stiffening of the heart valve. So if you manage your risk factors, maybe it will affect degeneration of this valve.
Thank you. Are murmurs or valve conditions an automatic trigger for an evaluation for an aortic aneurysm? Because I'm not certain of all the causes of an aortic aneurysm, but I'm pretty sure blood flow and irregular blood flow and turbulence in the aorta is one of those.
So people who are smokers, they are supposed to get an ultrasound to get a screening for aneurysm. And when we do the echocardiogram for this, we look at the aorta also, and we keep on looking at the size. If your size is bigger than 5.5, that is an indication for doing open heart surgery. And we follow these patients based upon the size of their aorta. We schedule them to see us in a year, 6 months, depending on what size it is.
Okay, thank you.
Yeah.
I actually have two questions. For some folks who smoked when they were in their 20s or 30s and now they're in their 50s or 60s or 70s, is there going to be a negative effect later on in life, 20, 30 years later, after they had quit smoking?
It is always beneficial to stop smoking. You cut your risk of heart attack by half the moment you stop smoking. But there are effects of smoking on your lungs and on developing this disease that we cannot quantify how much smoking is going to relate to this. But at any point, if you decide, it's a good idea to stop smoking.
Okay. The second question is, when you go in to the femoral artery and you put in a new valve,
Yes.
you're not opened up, so how do you attach that new valve to the area where the old valve is? How is it attached?
So if we just talk about this procedure, so the calcium on this heart valve helps us in sticking the valve into its position. So we crush the old valve along the wall of the artery, and this new valve sits in there. So this calcium grabs onto that valve and doesn't let it go anywhere. So
the
that's
calcium
how.
grabs onto the new valve and keeps it there.
Yes.
Oh, okay. Thank you.
All right. If there's no other questions, thank you very much for your attention.